Hello and welcome back to chapter 14. This is part 3 of the secondary assessment. We're going to talk about the reassessment and we're going to finish up the secondary assessment, rounding it all out. So reassessment. It continues on the initial steps of assessment. So remember back in our primary assessment, we did our ABCs. Make sure that we're checking our ABCs continually. Okay. It identifies changes and trends and must never be skipped, except when life-saving interventions prevent you from doing it. Now, that's not necessarily true. You should always be doing some type of reassessment at any given point. So it also identifies the changes to the patient, maybe subtle or profound changes, and then trends, deterioration, and improvement. Okay, so reassessment is an important part of the process, and it should probably never be skipped. So while we're doing this, we're going to communicate with the patient. We're going to explain the process, consider the patient's feelings, such as anxiety or embarrassment. Most patients are always apologetic to you, especially those who were injured. They feel like they have to apologize to you for them doing something stupid that got them hurt. And I just tell them, hey, if you weren't so stupid, I wouldn't have a job. I mean, you know, liven the mood, liven the tension, liven their anxiety just a little bit. I always tell them as well, if I've got a critical patient in the back of my truck, and we're pulling up to the hospital, I always tell them to, you know, just kind of relax. We're going to pull you out of the truck, take you in here, and once we get you into the room, you're going to have lots of people around us. They're going to start asking you all sorts of questions. Just tell them, you know, what you told me. And that usually helps calm them down a little bit. Okay, so the components of the reassessment. So we're going to repeat that primary assessment, recheck for life-threatening problems such as mental status, airway, breathing, rate and quality, pulse, skin, and reestablish your patient priorities. Because after you've done your reassessment and you find something, your priorities may have changed. Their airway may have gone downhill, or their breathing may have gone downhill. So, or they may have started to develop shock. So those are the things that we need to just be aware of. Okay. So a pediatric note, the mental status of an unresponsive child or infant can be checked by shouting or flicking the feet. And crying is an expected response from a child with adequate mental status. Again, I want a crying baby. If I don't have a crying baby, then it's an oh crap moment and it sucks. So I want a crying baby, as long as it's not my own. Yeah. So reassess and record vital signs, and compare those results with the baseline measurements that you got from your initial set of vital signs. Reevaluate the oxygen saturation and document findings to record and identify trends. So think of an example of a problem that might develop into a life threat to the patient on the way to the hospital. You know, they may start to develop shock more profoundly. They may have an airway issue. You know, when we picked them up, they had fallen, and we weren't really concerned with the chest, and they were breathing fine. They had an open airway, but then once we got to our detailed physical exam and we did a reassessment, we found out that there was bruising on the chest, indicating a possible like pneumo. So we need to be aware of that. Okay. So repeat pertinent parts of the history and physical exam. The chief complaint may have changed, especially with regard to severity. Ask about changes in symptoms, especially ones anticipated because of treatments administered. Okay, so check your interventions, see if they're working. The patient may have been complaining of pain in the leg, and then once we splinted it, he wasn't having any pain anymore. Okay. So repeat the physical exam to identify changes from the baseline, check any interventions. So when we check for interventions, we're going to ensure adequacy of oxygen delivery. So the oxygen that we've put them on, hey, is the SpO2 where it should be, okay? Or do we need to artificially ventilate the patient? Ensure management of bleeding. Check for, the gauze pads that we placed on a laceration. Are they bleeding through? Do we need to put more on? Do we need to maybe think about putting a pressure dressing on? Or do we need to maybe think about putting a tourniquet on? And then ensure adequacy of other interventions. Okay, check our interventions. So describe an example of an intervention that might need to be reevaluated and discuss your process for examining it. We talked about it, okay? So the oxygen. We need to make sure that our pulse ox is reading what we think our oxygen, how much oxygen we're putting in. So if they're on 15 liters non-rebreather and they're sitting at, 87%, hey, something's wrong, because I've got them on the 15 liters non-rebreather mask. So we need to reevaluate that and see what's going on. Okay, observing trends. Repeat the reassessment steps frequently. Establish and document trends. Trending. We're observing patterns that have emerged among the vital signs. Trends may indicate new treatments or adjustments to ongoing trends. Okay, reassess and record vital signs. So reassessment for stable and unstable patients. Patient's condition as well as length of time with the patient will determine how often you reassess. The more serious the patient's condition, the more often you'll reassess. Okay, so we're going to reassess every 15 for a stable patient and every 5 for an unstable patient, or even a potentially unstable patient. If you believe that there may have been a change in the patient's condition, repeat at least the primary assessment. Okay, so our ABCs. All right, so reassessment is the last step in your patient. You should reassess a stable patient at least every 15 minutes and an unstable patient at least every 5. Elements of the reassessment include repeating the primary assessment, repeating and recording vital signs, repeating pertinent parts of the history and physical exam, and checking the interventions you performed for the patient. So interventions you need to check include oxygen, bleeding, spinal immobilization, and splints. All right. Excuse me. So EMT diagnosis and critical thinking. You see that word? Baboon. Diagnosis. We do diagnose. We have to be able to diagnose to be able to treat our patient. Okay. So the traditional approach to reaching a diagnosis includes interviewing the patient in the controlled environment of a clinic or office. Okay. So how do clinicians reach a diagnosis? They have different levels of training, experience, technology, and other resources, and the techniques vary among types of clinicians. The traditional approach to diagnosis in medicine is to assess the patient, list of conditions or diagnoses, which we call this the differential or the differential diagnosis. Further evaluation, we're going to reevaluate the differential and final diagnosis. So basically, what you're going to do is you're going to assess the patient. You're going to find out what's going on, what kind of symptoms they have, what kind of problems they have. And then we're going to look at their medical history as well. Okay, so that all goes into it. Then we're going to list out what we think it could be. So the patient has chest pain. Okay, so there's a number of things that it could be. It could be a trauma. It could be a cardiac problem. It could be a respiratory problem. It could be a GI problem. Okay. So those are those things are my differential diagnosis. Okay. Then I'm going to do some further evaluation. That evaluation is going to include probably some tests. I'm going to do a 12 lead on the patient that has chest pain. I'm going to look at their EKG. I'm going to determine whether or not it's cardiac. Can't always tell if it's cardiac or not with just an EKG. You have to draw some labs and do some various other things. But further evaluation, a little bit further assessment in the exact problem, and tailoring your assessment to figure out what is going on with that patient. And then you can finally reach your diagnosis of, hey, I'm going to treat this as a cardiac problem, okay? Or I'm going to treat this as a respiratory problem, okay? So the emergency medicine approach to diagnosis, this is to quickly rule out and treat immediate life threats and stabilize the patient. And then we're going to return to gather additional information, focus on ruling out worst case scenario, any kind of red flags that may suggest a serious problem, and you may be responsible for multiple patients. So we don't have the time dedicated to, doing a focused one patient exam. Okay. The EMS approach to diagnosis has to be efficient, be available for another call as soon as possible. We work in uncontrolled environments. We have limited tools and skill sets and a narrow educational focus. It follows the same steps as an emergency physician. Most are abbreviated or limited. It considers most serious conditions associated with the patient. It rules them in or out, and we create that diagnosis from that. So you can reach a diagnosis, but your work is not done. Why? Even though we've gotten a diagnosis and we think we know what we're going to treat this patient for, it could be changed. It could be different than anything else. Okay. So a highly experienced clinician's approach to diagnosis in medicine. Experienced clinicians learn heuristics or shortcuts, pattern recognition, features, narrowing possibilities. So the more you get into it, the more experience you get, the more your assessments will start to focus in on certain things, like cardiac problems. Okay. The more you ask questions about the cardiac problem, I mean, I can teach you what questions to ask all day, but to get to a certain point and to get to a certain comfortability level with asking those questions and learning, hey, this med is for this and this med is for that. And then we can ask those other questions and kind of get in there. Okay. So it allows for efficient diagnosis and prompt treatment. It realizes that the limitations of shortcuts and understands the common biases of heuristics. So common heuristics are representativeness, availability, overconfidence, confirmation bias, illusory correlation, anchoring and adjusting, and search satisfying. So just be aware that even the most highly experienced clinician, because we have seen this. I mean, I've said it multiple times. I've seen this multiple times. I know what I'm looking at, and that is this. Okay. And we want it to be something. Okay. We know that this is this, so hey, we're just going to do it here and adjust it this way. Okay. So just be aware of those things. They happen. And they'll come in over time. Okay. So how an EMT can learn to think like an experienced physician. Learn to love ambiguity. Understand the limitations of technology and people. Realize that no one strategy works for everything, and form a strong foundation of knowledge. Um, in EMS, we learn. We continually learn. You have to continually learn to be able to be good at what you do. This little 6-month, 4-month class is not going to be able to teach you everything that you need to know to be an experienced EMT when you come out of it. Okay, I hate to say it, but all I'm doing is teaching you the basics, and once you get out in the field and you finish out your clinicals and you finish out everything like that, then you start learning. Okay. So organize the data in your head, change the way you think, and learn from others, and reflect on what you've learned. So what are some of the important things to remember as you learn how to make a diagnosis and improve your critical thinking skills in EMS? Okay. Um, so probably, um, me personally, I would say that you need to remember that you're not all-knowing. You don't know everything about medicine. I've been in EMS for 15 years, and I still don't know everything about medicine. I still don't know everything about paramedicine. So you've got to learn humility. And um, to me, I think learning humility will help you to um, keep your thoughts in check when you start to look at the diagnosis of a patient, and your critical thinking skills. Because when you start to think about all of that stuff, and you're still humble about where you are at in your learning process, um, then you can make a fairly good diagnosis to treat that patient. All right, so EMTs make some diagnoses in the field, although they are not extensive or as detailed as physicians. The traditional approach to reaching a diagnosis is to assess the patient, draw up a list of differential diagnoses, and assess further to rule in or out the different conditions, and then narrow that list until you reach a conclusion. Highly experienced physicians don't always use the traditional approach. They use heuristics, those shortcuts, in combination with their experience and training, which speeds up the process of reaching a diagnosis. And then we talked about these shortcomings. Just be aware of them. They're there. I don't care how good you are. They're there and they happen. So learn to think more critically by accepting the ambiguity of EMS working conditions, understanding limitations of people and technology, forming a strong foundation of knowledge, and organizing the data in your mind. Okay. When considering the cause of a patient's condition, don't let your search for a cause delay your treatment of the patient. If something has to be done for your patient right then and there, then I'm not totally worried about the cause of the problem. I just need to fix the problem. And happy coincidences happen, just like Bob Ross says. So when we look at fixing that problem, instead of trying to figure out the cause of the problem. What we're going to do is we could potentially find the cause of the problem while we're fixing the problem. So just be aware of that. Okay. Use the MOI to determine the need for a patient rapid trauma assessment, assume spinal injury, and work as a team to complete the assessment. So questions to consider. How did the focused physical exam of a trauma patient with a significant MOI differ from those for a trauma patient with no significant MOI? List the steps and areas covered in the rapid trauma assessment. How are these steps different in the detailed assessment? You are assessing a patient who fell 3 stories. He is unresponsive and bleeding into his airway. The driver of the ambulance is positioning the vehicle and bringing equipment to you. How do you balance the patient's need for airway control? He requires frequent suctioning with the need to assess his injuries. Okay. So if you are the only one there, the biggest thing that takes precedence over everything else is his airway. Okay. That's the first thing you've got to take care of. You can't take care of anything else. So, all right. So if you have, let's talk about your NREMT sheets for a minute. So down in the skills section of your online classroom, you have the NREMT skills. There's some videos in there. There's the medical assessment and the trauma assessment videos. I would strongly suggest going and reviewing those in regards to the assessments. Those are going to be focused. They're going to have like a scenario that they'll go through and do the assessment process. Okay. Look over those NREMT sheets, the medical and trauma assessments, and watch those videos as well. Okay. So if you have any questions, leave them down in the discussion post below, and you can also text me, call me, email me, whatever you need to do.